It's really an honor and a privilege to be able to give this talk. Um, so, you know, the main reason I'm doing this is because I myself am a victim of this phenomenon. I actually was, I did, a lot of the risk calculations myself and I was actually low risk for this. And even on the day of when it happened, when I basically had 3 stents put in, it was actually an acute MI STEMI. I was actually still low risk. So it really puzzled me. And so I'm going to just start by first, defining South Asians and also malignant coronary artery disease. South Asians are the people who live in the countries of the former British India and its diaspora. Namely countries like Pakistan, Bangladesh, India, Sri Lanka. And, you know, this particular ethnic group is predisposed to something called malignant coronary artery disease. And this is actually coined by a physician named Dr. Enos, who's written extensively on this. And he found that South Asians actually have a higher frequency of 3-vessel coronary artery disease. They have a higher amount of atheroma or plaque in their blood vessels. The size of the damage in the muscle or the infarct is larger, and the degree of how much it affects the beating function of the heart is much worse. And also, it's much more likely to be premature. We're talking about people in their 40s are getting this. So this is like a version of coronary artery disease that's somewhat very unique compared to the usual run-of-the-mill coronary artery disease. And this is why we have to know about this. It's actually very alarming statistics. 60% of all global coronary artery disease burden is in the world is actually South Asians are only 20% of the global population, but they incur 60% of all of the world's global coronary artery disease burden. South Asians have the highest proportionate mortality rate compared to any other ethnic group in the United States. According to the United Kingdom mortality data, the prevalence of deaths among South Asians 40 years or younger is 3 times the general population. 1 out of every 3 South Asians will die of coronary artery disease before reaching age 65. And this is with access to the best medical care, by the way. 4 times the rate of heart disease versus compared to Caucasians. We have the poorest coronary artery bypass graft outcomes amongst any other ethnicity. And on top of that, we have one of the highest rates of diabetes amongst all ethnic groups. In fact, it's 6 times the rate compared to Caucasians. And this list goes on and on. I mean, I could keep going here. Tragically, the epidemic is hidden. It's actually unknown to most South Asian people who, we call ourselves desis. Even physicians and researchers, until recently, most have been quite unaware, and perhaps even today, a lot of physicians are even unaware. And one of the problems was this confounding variable, which was that South Asians and East Asians or the rest of Asians were actually lumped together into the same ethnic subgroup. So East Asians typically have a relatively low coronary artery disease risk, and since most of the studies were done in places where the population was mostly East Asian, this alarming trend was actually hidden, even amongst the researchers. And on top of that, many South Asians will be surprised, do not believe, or frankly deny that they're overweight or actually have metabolic syndrome. The other major problem is that standard coronary artery risk calculators actually underestimate South Asian risk by up to 200%. If you use the well-known Framingham risk score or even the AHA, ACC, ASCVD score, it drastically underestimates the risk. I'm going to give an analogy. If there's raining, if you go for a weather forecast, the chance of rain should be 100% when it's actually raining, obviously. You know, you typically, you look outside, it's raining, you go on Google, go into, you know, what's the weather forecast, it'll say chance of rain 100%, you know, in wherever you live. So it should be 100%, right? Similarly, there's like weather forecasters for what are called coronary risk calculators that predict the risk of someone getting a heart attack in 10 years based on multiple different factors that are taken into account. It's really a very nice program, and it's typically very accurate. And keep in mind, you know, there's many of these. The four most commonly ones I'll be talking about. Greater than 20% is considered high risk, and greater than 40% is actually considered very high risk. So you would expect if someone's having a heart attack, obviously they should be in the very high risk category. So there was a study actually done amongst 149 South Asians who presented with an acute MI. While they were actually having this acute MI, and by the way, 83% of these were STEMIs, or the worst kind of heart attack. And they did a study where they just did the score on them. These are the most common risk calculators. When the Framingham risk score was done, 0% scored in the very high risk category. More than 62% scored less than 20%, basically low risk. Which is unbelievable. You know, the World Health Organization developed a risk calculator where only so in their risk calculator, only 2% scored in the very high risk category. You'd normally expect at least some, you know, large percentage of patients having to be in that very high risk category. Well, it's like only 2% if they're South Asian. And this is while they're having a heart attack, by the way. 87% scored less than 20%. If you use the AHA-ACC risk calculator, which is the most commonly used calculator in this country probably, only 9.4% scored greater than 40% in the very high risk category. Again, emphasizing this is while someone is actually having a heart attack, 100% having a heart attack. More than 70% scored less than 20%. The Joint British Society came up with a risk calculator also. It did slightly better. 18.3% actually scored greater than 40%. But what does that mean? You still have a huge percentage of the population who are South Asians who are actually having a heart attack. There's no doubt about this, who are scoring less than 20%. So this really illustrates the massive problem of underdiagnosis of South Asians. And if you look at the origin of these risk calculators, which are, by the way, are used, you know, basically in everyone to determine their risk. If you look at the Framingham risk score, it's actually, the origin is from a study based largely on white men in Framingham, Massachusetts. So it's no surprise. The AHA-ACC risk calculator is based on and validated amongst Caucasians and African American men and women. The World Health Organization risk calculator. You would think that would at least represent some South Asians. Nope, it's actually 2/3 of these were from recruited from European countries. 23% were from North America, and the remainder were mostly in Japan and Australia. So almost, I mean, basically zero representation of South Asians. And similar for the JBS3. So, you know, I actually, you know, what are the solutions for this? If you know, I was trying to figure out, is there some way to get around this serious problem? So, you know, there is one, the United Kingdom actually, since they do have a large South Asian population, they developed something called Q-Risk3 calculator, where they actually have South Asian as a specific risk factor. And even so, I did that. I actually did myself at the time I was having my heart attack. My risk score, and this is, by the way, this is based on different ethnicities, and they actually subdivide ethnicities into, South Asians actually divided into separate risk categories, because surprisingly, it's not all uniform. Actually, Pakistani and Bangladeshi people are actually significantly higher. So Q-Risk3 scores by ethnicity, you know, if I was Caucasian or white, my risk score was 7.5%. If I was any other type of Asian, 7.8%. Indian, 9.8%, Pakistani, 11.8%, Bangladeshi, 12.4%. Still, even with making that special risk factor, it's still relatively low for someone like me. So there's another way of doing it. Dr. Enos actually came up with a system, and he says, really, really can't be missing this obviously, because it's life or death. So he proposed actually multiplying the Framingham risk score by 2 times. Or the other option is to add 50 millimeters of blood pressure to the systolic blood pressure factor, which is a huge amount of additional blood pressure. Adding 100 milliliters per deciliter to the cholesterol number, and then multiplying the total cholesterol to HDL level by 1.5. So after correcting for that, it actually works to a decent level. You get up to 31.5% in my case. So at least now you can actually get into the high risk category. So that's one way of getting around it. The other way of getting around it is just to have this increased awareness among South Asians and their doctors, and understanding that not having the typical risk factors does not make you immune from coronary artery disease or a heart attack. It's really important also to consider getting coronary artery calcium scores. And even those may not be accurate 100%, but it may be better. And there's actually been research that this may be actually significantly better than any of the risk calculators, in fact. And then there's the other solution, which is to just put people of South Asian heritage after the age of 45 on some type of aggressive statin therapy, especially if they have an elevated coronary calcium score or abnormal lipids. So the next question, obviously came to my mind is, why is this? Why are we, out of all people on Earth, so affected by coronary artery disease? Initially when I was first hearing about this, I thought, okay, South Asians have smaller coronary artery disease. Well, actually, that's a common myth. The truth is actually that South Asians actually have smaller coronary arteries only because of their relatively smaller size. They actually, when you correct it for body surface area, there's actually no significant statistical difference because South Asian people are generally smaller. They will have less size of their coronary arteries. So that of course didn't answer the question to me, and I started doing some research myself as to what could be the solution here, as to why we're having this. It's like a curse. So the best that I could come up with is that it's a perfect storm, and this was really surprising to me. A perfect storm means it's an expression where it's not just one factor, but it's a coalescence of many, many different factors, each of which are extreme in and of themselves, which kind of amazed me to learn all of these factors are so severe in South Asians, and they all coalesce into one gigantic superstorm or perfect storm. By the way, it was based on a movie in the 1990s. So the perfect storm that I came up with is several factors. Survival history. We have a very unique history of survival, which I'll be talking about. We have something called serum lipoprotein A in our bloodstream, which is very, very elevated, and it's very disproportionately found in South Asians. We have metabolic syndrome, which is at a very high rate. We tend to have a very high tendency towards obesity, especially fat in the abdomen. Our diet is extremely poor, and I'll explain that. We have a quality of sedentariness. Of course, stress people know about, but sleep. South Asians, I'll be talking about this, we're actually very sleep deprived, unknowingly often. And then substance abuse, and this includes not just smoking and alcohol, but also supari. And then lack of sun exposure, which is really vitamin D, and then sugar and salt. And we have unique ways that our bodies deal with sugar and salt. So let me kind of open this up by talking about a case study of World War II, post-World War II Okinawa. Okinawa was actually one of the 5 blue zone regions on Earth. There's a guy named Dan Buettner who did a study of all the people of the world, and he found these 5 concentrations of people in the world, all of which are pretty isolated from one another, who follow this, a certain lifestyle and diet that allows them to have a very high concentration of people living over the age of 100. And the unique thing about this is that each of these places, the people pretty much do the same thing. And Okinawa was one of these. And of course, Okinawa is an island off the coast of Japan, if people aren't familiar. And what they do, they generally, in years past, they followed a very healthy diet, low calorie, nutrient dense, full of antioxidants, phytonutrients, low in what's called glycemic load, did not raise your blood sugar. And their lifestyle was great. I mean, they were very active, had a great social structure. And then what happened is that US military bases opened up in Okinawa, and it caused a rapid shift in food culture after World War II. So within a generation now, they're now known as Japan's fattest people, even though they're the second shortest people in Japan. They have the highest per capita spending on fast food. And now, unfortunately, they went from being ranked #1 in Japan's life expectancy regions now to the bottom half. This rapid deterioration occurred in the cardiovascular disease level, and it's basically amazing how quickly this can happen within a generation based on change in diet. So keep in mind that Okinawans are a non-starvation adapted people. Now imagine what would happen to a starvation adapted people, namely South Asians, and I'm going to be talking about this soon. So I think this is one of the factors that is what results in one of the highest rates of diabetes and heart attacks in the world. So I was really surprised to learn this. The story of South Asians is that of surviving British rule. South Asia for millennia or for thousands of years was the world's richest and most technologically advanced nation. In fact, 27 to 40% of the world's GDP came out of South Asia. And then within 190 years of colonialism, these countries became literally the poorest and most illiterate in the world. India, for instance, ended up with only 3% of the world's GDP. Per capita income was stagnant and in fact plummeted by 50% during the latter part of the 19th century. An unimaginable astronomical amount of wealth was extracted out of South Asia in 190 years. In fact, India had the second largest export surplus after the United States. And all of this massive export surplus was basically appropriated by Great Britain every year. So Indians were actually paid back with their own taxes, so they never benefited from any of this. And you can see what happened to the United States versus the status of India, even though India was right behind the United States in its export surplus and how much money it could have made from its exports. So, under British rule, it's really surprising to also know that life expectancy plummeted by 20%. I mean, people were living, life expectancy was only like 19 or 20 years of age in the 1920s. So there was actually 31 famines in 190 years of British rule versus 17 famines in the 2,000 years prior. 3 out of 10 of the deadliest famines in world history occurred during British rule. 6 out of 25 of the worst droughts and famines in world history occurred during British rule. By the way, none of these famines occurred before that. What made the list is only during British rule. This is actually unprecedented in South Asian history and probably the history of the world. The British actually did minimal relief for famine relief for what was compared to what was needed. And they set up, in fact, what were called famine relief camps where the mortality rate was in fact 94%. The starving refugees actually were paid in food, and this food was less, so they worked a full day, 9-hour day, and the food that they gotten, the rations, after working that full 9-hour day was less than the calories needed for a comatose patient to survive. These famine camps, by the way, held 10 million refugees, and it was a precursor to actually the concentration camps that the British developed during the Boer War, and was the model actually adapted later by the Nazis, in fact. So, what happened as a consequence of this? 85 million unnecessary deaths occurred due to these artificial famines. On top of that, when there weren't famines, most Indian peasant farmers didn't even have a single meal for most days of the year. And this is actually what the British are reporting themselves from Madras and Bengal. These are large portions of India where they didn't even have a single meal. Starvation occurred, by the way, because of taxation, heavy indebtedness. They actually had to go into debt to pay their taxes. And so they had to borrow money for that. And they were in perpetual indebtedness, a huge percentage of the population. And then India, as I mentioned, was actually, it was actually deindustrialized intentionally by the British. And all of these factors induced a massive level of impoverishment. And there was less and less food availability for every subsequent generation. The problem was that South Asian farmers were forced to grow cash crops for export instead of food. Billions of pounds of rice and wheat were exported during these famines to feed Britain and Europe. So, what does this mean? The data, there's actually been studies of famine survivors that have been done in various situations, like there's something called the Dutch winter famine in 1944, the Chinese famine. So even a single famine, in all of these studies, they've found that even a single famine, surviving a single famine, results in multi-generational increased risk for diabetes and coronary artery disease. Now, imagine surviving 31 famines. And that's the plight of South Asians. So switching gears here, another part of the perfect storm, serum lipoprotein A. So nearly half of South Asians have elevated lipoprotein A levels. This is in fact the most powerful independent risk factor for new and repeated heart attacks and early death in all men under the age of 45. Of South Asians, I mentioned half have elevated lipoprotein A levels, 25% have very, very high levels. The higher the level, the more aggressive the coronary artery disease. And unfortunately, this is not part of a routine check when you have coronary artery disease. This is not the routine screening. And the way that lipoprotein A works basically is that it causes blood clots to form and plaque formation inside blood vessels. And so, how much does it increase your risk of coronary artery disease? Up to 4 times. So I thought to myself, well, why is this going on? I mean, why do South Asians have elevated levels like this? I thought, well, maybe it must have conferred some level of survival benefit. Well, it turns out it does provide a survival benefit, and that it does during recurrent bouts of mass starvation, such as what the South Asians endured. So vitamin C is actually a critical dietary component, and if you don't get vitamin C, you obviously will die. And this is actually what happened to sailors when they didn't get vitamin C, is they developed scurvy and they died on these long distance voyages, as probably people have heard of. And the solution was vitamin C. Well, South Asians, of course, did not have access to any food or any vitamin C containing foods. So it was survival of the fittest, and lipoprotein A was a selection process, a natural selection that resulted in them surviving, because it's basically a jimmy-rigged version of vitamin C. And the way it worked is that under British rule, if you only live to the age of 19 or 20, lipoprotein A is perfect as a substitute for vitamin C. But what happened is that as soon as the British left, life expectancy skyrocketed. And this is with almost zero spending on healthcare. Life expectancy skyrocketed to like 60s and 70s, and I should say really 60s. And then what happened is that people started living longer, and now they're getting affected by what's called a rogue version of vitamin C, where you actually, serum lipoprotein A starts actually forming plaques and blood clots inside blood vessels once you start living beyond the age into your 30s and 40s. So the problem is that there's actually no currently available lipoprotein A lowering medication. In fact, diet and exercise cannot modify your levels. Baby aspirin can actually lower your lipoprotein A, but it's not actually FDA approved for this. Really, the solution is screening, and to make sure that your LDL level, as much as possible, is brought down to a low level with aggressive or high intensity statin therapy. Other solutions would be possibly vitamin C, and key is to avoid trans fats. Trans fats, such as found in donuts, cakes, and fried foods, actually increase your not only your LDL and triglyceride levels, but also your lipoprotein A levels. So the lesson I've been learning is that South Asians are actually cut from a different cloth. What applies to Caucasians or perhaps the rest of the ethnicities in the world doesn't actually apply to South Asians. And I learned this when there was actually a recent study that was done on healthy Caucasians and healthy South Asians. They were each given a cup of cream for 5 days. And a cup of cream basically is like 28 grams of saturated fat. It's not a huge amount, in fact. All of the South Asians within 5 days developed prediabetes. None of the Caucasians were affected. So we are actually at high risk for something called metabolic syndrome or insulin resistance. And there's a quote actually from Dr. Sinha, who's actually another expert on this. If someone were to ask me in one word, the primary reason South Asians have a high risk of heart disease, diabetes, excess body fat, fatigue, and a number of other health conditions, my answer would be insulin resistance. So let's talk now about insulin resistance. This is another part of the perfect storm. Insulin levels actually become very high in insulin when you have insulin resistance in response to a standard amount of sugar intake, or basically in response to any type of glucose or any type of food that has carbohydrates. Insulin levels become very high. And this occurs generally because the liver and muscles are already full of glycogen, which is a stored form of sugar, and there's no place for the sugar to go because insulin actually drives the sugar levels down inside the bloodstream. Of course, if you don't do that, you'd be in big trouble. So when insulin can't do its job, the pancreas has to generate even more levels of insulin to do the same job that it normally could have done with, let's say, a much less level of insulin. So this is called insulin resistance. And the analogy here is, in Japan, think of this as there's a person called an Oshia. His job is to stuff people into the subway trains. And this is analogous to an insulin molecule trying to stuff glucose into the cells of your body that, like your muscles, that are already full of glycogen. It's really tough to do that, and you need a lot more, of these guys or insulin molecules to do the same job that it would have taken maybe almost very little of these guys to do before. So metabolic syndrome is a consequence of prediabetes or insulin resistance. And Indians are actually very prone to metabolic syndrome and insulin resistance. In fact, even neonates have like very high insulin levels compared to other children born or newborns in the world. And the profile of South Asians is like an extreme version of the typical metabolic syndrome profile. The LDL levels is more atherogenic, meaning this is a cholesterol type particle, and it's the worst type of cholesterol, and this is actually more atherogenic in South Asians because they're much smaller, even with normal levels. And there's something called triglyceride, which is the fat molecules. 70% of South Asians have this versus only 34% of Caucasians have elevated levels. South Asians also have a very low HDL level, which is, of course, the good cholesterol. It's the protective portion of cholesterol. But uniquely, the most protective subfraction is low in 90% of South Asians. And it's thought that this is due to the diet and the lack of exercise that South Asians typically have, and I'll be talking about that later. South Asians, as a result of metabolic syndrome, they're prone to high blood pressure, and we talked about insulin resistance. We accumulate fat inside our abdomens, which is, by the way, the worst place to get fat. And we have another sign of metabolic syndrome. We have very high triglyceride to HDL ratios, and we have very high LDL to total cholesterol ratios. In fact, we have the highest total cholesterol to HDL ratio of any ethnic group. And we have the highest what's called apolipoprotein B to apolipoprotein A ratio of any ethnic group. And this is actually the most robust predictor of heart disease derived from blood tests. And on top of that, I mentioned earlier, we have a much higher insulin level and higher insulin response to the same glucose load that that a, say a Caucasian person would have like very less response to. The other interesting thing is that South Asian vegetarians are not that protected. They're only protected slightly from diabetes, but not metabolic syndrome and obesity. And this actually is a surprise because it contrasts with Seventh-day Adventists who are actually in the blue zone. They're vegan. And also vegans, as studied by Dean Ornish, who proposed veganism to reverse coronary artery disease. So why is this? It's because of something called contaminated vegetarianism or westernized vegetarianism. So processed foods, often South Asian vegetarians eat a lot of processed foods, white rice. They have a diet high in refined grains, low protein, high in sugary beverages, higher than usual amount of fast foods, a diet high in omega-6 rich hydrogenated oils, trans fats, saturated fats, full fat dairy is often eaten, including ghee and other dairy foods. Low in fresh fruits, tree nuts, and vegetables. And by the way, the vegetables are often overcooked, and low fiber. The other problem is frequent consumption of calorie-dense festival type foods, which are high in sugar, salt, and other fats, invisible fats. Inappropriately large portion sizes, low activity, and high stress. So even South Asian vegetarians are generally not protected. So what are the solutions for metabolic syndrome? It's really to reduce your abdominal obesity. Weight loss is key. Even 5 to 10% weight loss by avoiding overeating can make a massive difference. Avoid refined carbohydrates. Try to keep saturated fat intake less than 13 grams per day. This is actually what the American Heart Association recommends. And trans fats. Try to reduce the frequency of eating or intermittent fasting if possible. Try exercising. I mean, that actually lowers the glycogen stores in your muscles. And don't forget, resistance training is actually especially effective because it actually increases your muscle mass and actually provides a way to store more glycogen so that insulin can actually do its job better. You want to reduce stress and get enough sleep, and you want to aggressively treat dyslipidemia or the abnormal lipids. And then there's some literature that suggests that it's important to check the ApoB or ApoA1 ratio, or even at least ApoB levels. And it may actually be simpler to do this and actually be more accurate to at least judge the risk in South Asians compared to doing all the other tests. Of course, I'm not saying you shouldn't do that, but it may be another way to add to as an adjunctive test. And then you want to do all the lifestyle modifications and medications when these abnormal studies are found. Inflammation is another problem. Central abdominal obesity, which is part of metabolic syndrome due to the visceral fat, generates inflammation, and that's what actually causes this problem with heart disease. The other issue is the diets, which tend to be in these carbohydrates, sugars, fats, and red and processed meats will also be very bad for creating inflammation. Lack of fresh fruits and vegetables, I talked about legumes and nuts. And then insulin resistance, and South Asians actually have elevated C-reactive protein more than other ethnic groups. Of course, high stress, sleep deprivation, and periodontal disease, I'll be talking about that later, but all of these result in higher inflammation rates, which predisposes to coronary artery disease. Let's talk about obesity or shape. The criteria for being overweight and obese are actually vastly different for South Asians versus Caucasians. This is because of something called thin fat syndrome. The BMI actually underestimates the amount of fat inside a South Asian person due to a low amount of lean muscle mass in South Asians. And I actually sort of somehow skipped over this, but it's actually a factor of survival to survive the starvation that South Asians have a relatively low amount of muscle mass compared to other ethnic groups. We have also 3 to 5% higher body fat at any given BMI compared to any other ethnic group. And we have the highest body fat of any Asians. It's even seen in neonates despite lower birth weight. There's a combination of waist circumference. So a combination of waist circumference or waist to height ratio may actually be better than a BMI. And this is actually an example of two different people with the same exact BMI. This is a South Asian. His body fat percentage is, his BMI is 22.3. His body fat percentage is 21.2%. This is a Caucasian. Same BMI, 22.3, but his body fat percentage is only 9.1%. So it's amazing how different it is. The other thing is the test for obesity. When you can't see your feet when you're looking down, it's actually abnormal. You should probably try this. If you're moderately obese, you can only see your toes, but not the rest of your foot. If you're severely obese, you can't even see your toes. Comparison of criteria. This is something that's very much a surprise. For metabolic syndrome, it starts in South Asians when the BMI is greater than 23, versus in Caucasians, it doesn't start until the BMI is greater than 30. Same thing with abdominal waist circumference. In a Caucasian person, in a South Asian person, it's seen as soon as the waist circumference gets more than 35.5 inches, versus a Caucasian person, a Caucasian man, 40 inches. It's a big difference, actually. And this is why obesity never gets flagged for South Asians in our electronic medical record system. Because if your BMI is 23 or greater than 23, I should say, you're considered overweight. If your BMI is 25, you're not only overweight, but you're actually obese. A Caucasian person is actually considered normal with a BMI of 25, by the way, not even overweight versus a South Asian being obese. Okay, and then this is another interesting fact here. You know, Pima Indians, I'm sure people are familiar with Pima Indians. They're known archetypically for having the highest prevalence of diabetes due to a shift from their traditional diet. Interestingly, South Asians actually have 5 times the rate of Pima Indians of diabetes when their BMI is less than 25. It's nearly, and then at the other BMIs, it's nearly the same incidence. And it's generally, this is not known. I mean, everyone knows about Pima Indians, but people rarely know about South Asian Indians. So the solutions for weight control, again, are similar. Reduce calorie intake, increase water intake, fresh fruits, vegetables, tree nuts, exercise, get enough sleep, reduce stress. Sustenance is another part of the perfect storm. South Asians eat more white rice than any other people on earth. Each cup of white rice increases the risk of diabetes by 11%, meanwhile. And this is like an example of the extreme amount of white rice consumption in South Asia. The average person eats 630 grams per day, versus in the second highest country is China. I mean, China is known for eating rice also, but it's less than 1/3. That's the second highest country in terms of per capita consumption of white rice. So this is the problem. You know, each cup increases the risk of diabetes by 11%. And if you're eating multiple servings of this, it's like, you know, very, very bad. So there's also a myth that traditional fats like ghee, which is clarified butter, or coconut oil are somehow healthy fats and oils for South Asians, when in fact science tells us they are not. There's actually a quote from one of the journal articles. It's surprising, but this is not good for us either. Low consumption of fresh fruits and vegetables. We actually carry around the lowest levels of vitamin C. Vegetables are often overcooked, and the folate, that's actually the protective element of vegetables, is destroyed as a result of that. The other interesting thing is, you know, a lot of rice and grains actually have a high level of pesticides, and this actually increases the risk of heart disease by 3-fold. It also increases your risk of early death by 50%. So the key here is to really go organic if possible. Okay, the other part of the perfect storm is sleep. South Asians are actually predisposed to obstructive sleep apnea at much lower BMI thresholds compared to other ethnic groups. Sleep loss as a result of just not getting enough sleep in general, or perhaps due to sleep apnea, predisposes you to atherosclerosis and heart attacks. And Fitbit found this interestingly. Indians are actually the second most sleep deprived, just above Japan. And similar to Japan, South Asia, Indians have the lowest amount of REM sleep per night. And any type of interrupted sleep prevents fat loss. Sleep is actually when you can actually lose fat. And if you're having interrupted sleep, such as if you have obstructive sleep apnea, basically you'll have 0 fat loss. The other thing is, you know, what are the solutions? I mean, let me just go into just the sleep deprivation part. It's actually an independent risk factor for heart attacks. the right amount of sleep matters. If you're sleeping less than 6 hours per night, your increased risk of 20%. If you're getting less than 5 hours, 52% increased risk of heart attack. You're increasing your risk of insulin resistance, diabetes, and coronary artery disease with this. If you're South Asian, even if you are sleeping a normal amount, you may not be getting enough sleep. Did you know that snoring is actually a sign of obstructive sleep apnea? This is lost on many people. Other signs include daytime sleepiness, not feeling refreshed after sleep in the morning. And by the way, coffee will mask all of these symptoms. Coffee in the morning will mask all of these symptoms, so you may not even realize this. But snoring in South Asians only is a sign of obstructive sleep apnea, and it doubles your risk of developing type 2 diabetes mellitus. The rate of obstructive sleep apnea in South Asians is 7.5%, which is actually double the rate of Western countries and even Eastern countries. And furthermore, if you're severely obese as a South Asian, the rate is 43% versus only 22% for Caucasians. So as I mentioned before, South Asia, lack of sleep is bad. Sleep apnea itself is also really bad. Coronary artery disease increases by 30%, heart failure by 140%, risk of stroke by 60%. Really, the solution is simple. You really need to get enough sleep. Make sure that you are very dedicated when you are sleeping. Get tested for sleep apnea also, because you may be thinking you're sleeping enough, but you may not be getting enough sleep because of sleep apnea. Stress. Okay, stress, obviously, South Asians probably have a lot of stress. I mean, we are in very stressful occupations. There's a lot of expectations. There's the socioeconomic stress. There's acculturative stress from adjusting to a different culture. And then, of course, if you are, an immigrant, there's anti-immigrant sentiments, anti-Muslim sentiments. South Asians actually have the stress hormone, by the way, is cortisol. They actually have lower levels of cortisol, but it's more than made up for by the fact that they have a greater sensitivity to cortisol. So cortisol actually promotes abdominal obesity, hypertension, metabolic syndrome, and heart attacks. Chronic stress is associated with 3 times increased risk of heart disease. And there's actually a syndrome of acute stress called broken heart syndrome where you can actually die from it acutely. So the solutions are pretty straightforward: stress management, deep breathing exercises, yoga, meditation. By the way, yoga and meditation, of course, South Asian origin. Avoid overeating and poor diet also due to stress, which can compound the problem. Substance abuse. This is another part of the perfect storm. Nicotine is highly addictive, and tobacco can cause you to form plaques inside your blood vessels within 5 minutes. Most deaths from smoking are due to heart attacks. There's actually very high rates of smoking in South Asian countries compared to the United States, 19.1% versus 43.3%. Within the top tier of countries with smoking-related deaths are in South Asia, actually, in the world. Another problem is supari. People are probably familiar with betel nut or supari. It's a very, uniquely South Asian treat, I would say, after dessert or after, any type of party. This is actually a neglected global public health emergency. 10 to 20% of the population actually uses supari. It increases the risk of coronary artery disease by 7.7 times, the risk of a heart attack by 3 times. The FDA does not even consider it safe for chewing or eating. The other thing is spirits or alcohol. I know a lot of Muslim people probably don't drink, but that's not necessarily the case. But South Asians are actually particularly vulnerable. Increased risk of stroke and heart attacks compared to Caucasians. The American Lancet had an article in 2017 discovered, it used to be that moderate alcohol consumption was supposedly good for the heart. It actually was found, according to that no level of alcohol consumption is safe, not even 1 drink per day. And this is the latest information that did on hundreds of thousands of people. They did this research over many years, and they made this conclusion, and this was published in Lancet, which is one of the most prestigious journals in medicine. And there's been, unfortunately, a huge rise in alcohol uses in India between 2010 and 2017. Vitamin D is another problem. There's a major deficiency among South Asians, not especially in temperate climates like people who are in the diaspora, but also even amongst the South Asian countries, surprisingly, because of cultural reasons. People just don't go out in the sun enough to get their vitamin D. There's a possible link with heart attacks and a definite link with diabetes and insulin resistance. The other problem is periodontal disease. This is actually the tip of the iceberg for inflammation. India was actually ranked as the second worst country in oral health care. 95% of adults in India have periodontal disease. Inflammation due to periodontal disease is actually a major risk factor for heart attacks and diabetes. There are many solutions. Of course, you want to go to a dentist, but you want to do all the other things to reduce your inflammation also, as I described previously. Get your teeth cleaned regularly, floss every night, brush your teeth every night. And then there's sugar. Sugar is another interesting part of the perfect storm. Sugar was actually invented in India, by the way, and so was candy. But South Asians are more prone to developing what's called a lipogenic response from sugar than other ethnicities, especially Caucasians. I mean, this is actually what happens to the increase in like fat production after eating sugar. And black is South Asians. See how much worse it is when we eat sugar for our bodies compared to a Caucasian? Sugar is actually akin to alcohol. It's actually toxic to the liver. Our bodies evolutionarily were not designed to intake sugar or table sugar or fructose. It's actually also addictive. So it's directly responsible for non-alcoholic fatty liver disease, which is basically a precursor to insulin resistance and metabolic syndrome. Fructose, which is found in table sugar, is a highly lipogenic sugar. The other problem is the use of palm sugar and coconut oil in Indian diets and South Indian foods. This actually promotes insulin resistance directly in fat cells. So the solution obviously is to avoid sugar. Although addiction to sugar makes it more difficult, it's actually much worse for South Asians compared to Caucasians, for instance. Salt, this is another problem. The American Heart Association recommends ideally less than 1.5 grams per day. South Asians on average consume a whopping 11 grams per day. In the US, the average is only 3.4 grams a day. And why is this? Is because in South Asian food, often salt is hidden because of the spiciness of the food. So the salt sensitivity of South Asians is another problem that compounds this. Now, why is this? South Asians actually had to adapt to numerous droughts that occurred as a result of deforestation under British rule due to having to plant cash crops for the British. So as a result of this, South Asians adapted to adapted to droughts, these numerous droughts that occurred under British colonialism. And how do you adapt to that? You actually have to your body has to be very, it has to retain salt very much. And that works great if you're surviving a drought, but if you have normal amounts of salt in your diet or even high amounts of salt, it's terrible for your body. And then on top of that was what's called a salt tax. This was also interesting historically. The salt tax was raised by 11 times under British rule. This was almost unaffordable. It was actually 2 months average earning salary of a wage earner in India to just afford the amount of salt that you would need for a year. Salt consumption was reduced to, drastically as a result of this. So our bodies adapted to lack of salt. And now after independence, when the salt tax is gone, South Asians are loading our bodies with salt in a body that is not used to salt. So what happens? Hypertension, chronic kidney disease, and stroke. A blood pressure of 120/80 is actually abnormally high, according to the American Heart Association. The other problem is that there's what's called silent hypertension in South Asians. When South Asians blood pressure is like say after any type of exertion, it's actually the recovery or the return to normal is actually impaired. So this actually worsens the effects of even a slightly high blood pressure because it's the time duration of the elevated blood pressure that causes the damage. So so this is really bad. I mean, the consequences are chronic kidney disease. I mean, this is actually even a worse emergency than the heart health crisis. 4 out of 10 South Asians have some degree of chronic kidney disease that's underdiagnosed. South Asians are 3 to 5 times more likely to develop renal failure than Caucasians. South Asians with diabetes are 10 times more likely than Caucasians to develop renal failure. The Cardiorenal Society of America says rates of cardiometabolic renal disease are extremely high amongst South Asians. And not only in their home countries, but also worldwide. And actually, Bangladeshis are even more prone. Stroke as a result of high blood pressure. 2 to 3 times higher mortality for the same stroke in South Asians. And alcohol actually worsens that. especially for South Asians. The effect of alcohol is actually more severe in terms of causing worse outcome from stroke. And then 40% of all stroke deaths in the world actually occur in South Asians, and they occur 10 years younger. So the solution obviously is to minimize or avoid salt consumption. And I know it's difficult to do this, but it's really something that our bodies need to be aware of, or at least people need to be aware of, because our bodies are different. So in summary, there's an increased risk in South Asians is underestimated, and most people are completely unaware of this. South Asians are naturally predisposed to diabetes mellitus and coronary artery disease, and not to mention other diseases at a very, very high rate because of things like lipoprotein A, because of the high concentration of apolipoprotein B, metabolic syndrome, obesity. It's really a perfect storm. I mean, it's poor diet, which is extreme. You know, we mentioned white rice, high levels of saturated fat, you know, ghee, coconut oil, poor sleep because of obstructive sleep apnea, or just not getting enough sleep in general, or probably compounded also by high stress levels, poor activity levels, not enough exercise, high levels of stress, substance abuse, lack of sun, periodontal disease, starvation adaptation, and drought adaptation. I think there was one other topic here that I didn't go into, which is sedentariness. This is another big factor in I think, I don't know if I skipped over this somehow, but South Asians are actually the least active of any ethnic group. This is actually, Fitbit found this. Indians are the least active, and this kind of reflects what happens in other South Asian countries. It's South Asians, paradoxically, not only are the least active, but they paradoxically need almost twice as much exercise as a Caucasian to maintain the same level of health. So exercise is not a choice. South Asians actually need 260 minutes of moderate intensity exercise weekly. So basically, you know, as I mentioned, this is it's all part of the unique perfect storm that South Asians have. Now, the good news is that lifestyle modification can actually reduce acquired risk factors. You know, serum lipids and lipoprotein, you need to get it checked and get it treated aggressively. Insulin resistance can be reversed if you do the things that you need to do. Size, it's so important to lose the belly. Sustenance, eat less and properly. Exercise 260 minutes per week. Avoid stress, and try to manage stress, really. Get enough sleep. Get tested for obstructive sleep apnea. Regarding substance abuse, you know, no sapari, no smoking, no alcohol. Get more vitamin D, and by, you know, go outside, expose yourself to the sun, or take vitamin D tablets. Avoid excess sugar and salt, and know our unique survival history. You know, British colonialism actually transformed our bodies and made us particularly different. You know, we are more susceptible to sugar. We're more susceptible to saturated fat than Caucasians are. I mean, our bodies are uniquely different. I was going to just put this one thing. So, you know, one of the things about the adaptation from starvation, low lean muscle mass, we have the high percentage to store fat, yet the fat that we store is malfunctional. It actually results in toxic visceral fat because we store it our bodies are so unused to storing fat that they store it in the wrong place, which is the most dangerous place between our organs. Unlike, you know, say Caucasians who store it in the right places, like say in their hips, buttocks, in their, you know, subcutaneous regions, we store ours in more likely in between our organs, which is the worst place to store it. It causes the worst. It's toxic, actually. And then, you know, insulin resistance, another adaptation to starvation, because what does insulin do? If you have high insulin levels, you can store more fat. Lipoprotein A, I mentioned, was a vitamin C analog. Sedentariness is a cultural relic of starvation adaptation. Salt adaptation is an adaptation to the droughts and the salt tax. So our bodies have been made through these evolutionary adaptations to survive, very different from perhaps any other people on Earth. And so we have to be a lot more careful with our bodies. Thank you. I think that's basically it. Any questions?
Wow, that was.
I'm sorry it took so long.
Oh, no, that was incredible. I don't. There's so much to unpack. I mean, starting with that colonialism is still killing us. You know.
Yes, the effects of colonialism tragically are still affecting our bodies. This is something that's very much lost on people, and it's really, you know, a lot of. It's probably going to take multiple generations to correct this.
Yeah, and I was going to ask, one of the questions was, what do you think about different cardiac imaging for risk stratification?
Yeah, I think coronary calcium scores are excellent. If that would be a really good place to start. Of course, depending on your risk factors and your presentation, a coronary angiogram, but really the least invasive and probably the most bang for your buck is coronary calcium score, in addition to all the other risk factors that I mentioned.
Okay. Yeah. I mean, I can just speak from my area in Chicago. Advocate Aurora has a coronary calcium score, which is $50, and you don't need a doctor's order to get it done. I think that's a great screening tool. It's a good start of a diagnostic workup. I don't think that's the end of it. My friend recently, he had a coronary calcium score 2 years ago, which ended up being negative. And then 2 years later, he actually had a nuclear stress test, which was also negative, but he had classic angina.
Hmm.
So they continued on the diagnostic workup because, exertional chest pain, South Asian descent.
Hmm.
He kind of worked very closely with his doctors. He knew them. So it
Yep.
helped him push for safety of his coronaries, which
Yep.
showed the triple vessel disease ended up getting stented.
Hmm.
But
CT coronary angiogram you're talking about?
CT
Yeah,
coronaries, yeah.
that's an excellent test also, yes.
And the reason I bring this up is, and this to your point, there's no beautiful algorithm that gets you to the perfect
Hmm.
um, diagnostic workup, right? Like you
Yep.
could be from the Framingham risk score you just showed us, you could be like very low risk and
Hmm.
still very high risk in
Yep.
actuality.
Yep.
So, yeah, any other
So,
thoughts?
I mean, South Asian, just being South Asian itself is like it's equivalent to being diabetic. You got to be very suspicious without the diabetes, of course.
Yeah, but to your point, I think South Asians kind of have to push some of the diagnostic workup more than usual. So whenever I ask people about their stories, it took quite a few attempts to continue the workup, right? A negative
Yep.
stress test in a low risk person generally would be suitable, but
Hmm.
in a South Asian could be very problematic.
Yep.
Um,
It's really the lesson here is you just have to be super suspicious. High index of suspicion is necessary,
okay,
even if certain tests are perhaps negative. With the appropriate clinical presentation or you know.
sure.
Visceral fat that you talked about
Yes.
is the most dangerous thing. Are there any new medicines on horizon that may help some people?
Yeah, there are actually, FDA has been approving, I mean, if, you know, changing your diet and exercise doesn't work, there are obesity medicine specialists out there who can help people. There are numerous medications out there that can be of benefit. And there's ones that are constantly being FDA approved. There was one recently that actually came into the limelight recently, and there's holding a huge promise. But there are many drugs out there that can be used safely if needed.
Um, One question from Fahad Ahmed: should we prefer pink salt, knowing iodine is not present in it?
You know, it's the sodium, unfortunately, that's the problem.
Mhm.
It's not the iodine, it's the sodium. And I think Himalayan salt probably has a lot of sodium just as much as table salt. Potassium actually is a good salt if you can get past it. I actually like potassium as a salt substitute. It tastes salty, and it may not be completely like salt, but or even like a 50-50 mixture of potassium chloride or potassium related salt and sodium chloride. You can actually get pretty good flavoring to food without as much salt.
This is maybe I don't know what the technical thing here. Someone asked, is Gogopan also one of the culprits like Supari? I don't know what's in Gogopan, but
I think gogo, if it contains betel nut, it's the
yeah.
problem. Betel nut or sapari. I mean, what's in the center of it is what matters, not the actual betel leaf so much as what's in the center of it.
And one thing that can obviously, these lipid profiles are not indicative of what's going on inside the blood vessel wall in the
Hmm.
coronaries, but also a general guideline, we need to have our lipid panels checked
Yep.
more frequently and probably earlier
Right.
than the general population.
And there's a recent article, like I mentioned, that ApoB levels may actually be a little bit simpler and may actually properly weight the give risk properly weight the risk of a South Asian compared to a standard LDL and HDL levels, because oftentimes in these risk calculators, things like triglyceride levels, which are very high in South Asians and are known to be an independent risk factor for coronary artery disease, are not really taken into account, and we have sky high levels of triglyceride, and that's part of the problem.
Okay. There's one
Yeah,
more. Oh, go ahead.
go ahead. No, we all come from Hyderabad. Apparently, it's a diabetic center of the world. The
Yep.
highest incidence.
Hmm.
Absolutely. One more question from from Talha Khan. It sounds like lowering body fat percent dash age might be incredibly protective and address multiple risk factors. But
Yes.
this is very difficult. Why isn't there more of a focus on this yet in our community?
um I'm hoping to correct that by giving this knowledge to people. It is, perhaps it's somewhat ingrained that, I know in our society, like in my background, coming from where I come from in India, having a good belly is actually a sign of success. It's a sign that you've made it. It's actually someone who's distinguished because they have the ability to have a belly. It's not seen as something that's really dangerous. It's a lot of it is just people just don't know how bad it is for you. And of course, the other problem is once you get it, it's really difficult to correct it. I can tell you just from my own experience, I've had to lose like 40 pounds, by the way. And I had a very difficult time losing that. It takes much longer because of the insulin resistance to lose the same amount of fat that it would for some other person. We actually are, because of the chronically elevated insulin levels that we have, insulin tells the body to store fat, store fat, store fat. So if the levels are already high, you actually have to try a little bit harder. I mean, it's doable. I mean, that's why I think, one of the good things that Muslims fast during Ramadan, it's actually a good way to lose fat as long as you do the right things after, during iftar or during suhoor. You don't want to eat things that have a lot of sugar, and you really want to eat a good diet before and after your fast.
Okay. One more question.
Because it actually lowers your insulin level, when you're fasting.
Sure. Yeah. No. Definitely.
That's what's the magic of fasting, is it drops your insulin levels really, really low. And that's the only time you can lose fat, is when your insulin levels are low.
Yeah.
One more question. How or who orders an ApoB level?
So this is something that, a physician can order for you. They're actually pretty inexpensive, by the way. They're like, I've looked it up on the internet. It's like $60. Maybe it's probably as much as $100, but closer to $60. You can get it done. Most labs can actually do it. It's readily available in most labs. And this can actually, it's a very robust indicator of your risk. And it can actually be easily followed as like a single number. It can actually be, I mean, there's the European Cardiology Society is actually now recommending this.
Okay.
As a better robust indicator compared to LDL and the other, and total cholesterol, for instance, because there's some issues with LDL and the other things that are not well measured, like VLDL and triglyceride levels that are not included in these risk calculators.
You pointed out the wrong oils.
Yes.
Do you have recommendations for the good oils for people?
Yes, I would say that's a very important point. We should not be intaking coconut oil. A lot of people think, oh, coconut oil is good for you. It might be good for Caucasians, but it's not good for us. We're made differently. So a lot of Caucasians think, oh yeah, it's fine. Yeah, and you know, you could probably even do a study, and the Caucasian will have no problems. But if you do the same thing for South Asians, will become pre-diabetic because it's huge amounts of saturated fat. And I already mentioned this, but olive oil, monounsaturated fatty acids like olive oil, avocado oil, those are excellent fats that you can use, oils that you can use in cooking. I mean, you don't want to use the other, like, you know, in fact, there's something called vanaspati, which is called vegetable ghee that's often used in a lot of South Asian countries. That's actually toxic. It's filled with trans fat and it's deadly. So really avocado oil and olive oil are probably the best ones I would suggest for use. And make sure, by the way, that it's, I would say make sure that it's true olive oil. A lot of olive oil in this country is unfortunately adulterated. It's like they will add some of the bad oils into it. Like California is a good place to get your olive oil from.
Okay.
I think the cold pressed, cold first squeeze is probably the best.
Definitely. Yep.
Okay. We'll do one more question, then we'll go for some closing remarks. Are there specific protein requirements for South Asian in order to increase muscle mass / lower body fat?
I would say that you want to increase, you definitely want to increase your protein intake. And see, unfortunately, a lot of South Asians, a typical diet is oftentimes 80% carbohydrates. You want to actually, and this is like a typical, I was shocked when I learned this. So you want to reduce your carbohydrate intake and replace it with protein. In terms of protein, I mean, I have it in my book. I don't actually have it off the top of my head, but you know, you probably want to increase like good protein. You want to avoid you know, red meat as much as possible because of the saturated fat that comes with it. You know, there's other forms of protein like fish that you can try, or even vegetable proteins that can be very good for you. Those are the proteins you want to intake, and you really don't need a lot. I actually, off the top of my head, I'm blanking on how many grams per kilogram a protein intake is. I'm forgetting, but anyways, I'll have to look that up.
Yeah.
But it's not that much, surprisingly.
Okay. All right. Just a couple of things. Can we get permission to use some of your slides for presentation in our community? I'm gonna say, what's the best way for people to reach out to you if they wanted to talk to you about something, or have you give this presentation somewhere else, or?
Yeah, I mean, I would be happy to present this on Zoom somewhere else if people would like me to do that. You know.
Is there an email, or what's the best way?
Yeah, I mean, my email is MUBINSYED. It's my first name and last name at AOL.com.
Someone who still uses AOL, that's amazing.
Yeah, it works.
It works.
It tends not to get hacked.
Okay. I'm going to take one last question, because I know this is an issue, and they call me White Rice Shahab because I love white rice. How much rice on a daily basis is okay?
So first of all, you know, I eat rice, and I think I can go into my slide on this. You know, one of the solutions for sustenance, I think I may not have gone into it clearly, is to go for brown rice. You know, white rice was actually introduced by the British. Our ancestors never ate white rice. White rice is actually a bad form of rice for our bodies. All of the healthful benefits of rice is in the husk or outer layer. Brown rice is what our people ate for thousands of years. And it was called hand-pounded brown rice is what we ate. So we should be eating brown rice if at all possible. And a lot of times, you know, you can get some very good versions of brown rice that taste very similar to white rice. And we actually, I mean, I can give you specifics on that. It can be very, you know, much better if you can do it. Let me see if I can, under solutions here. Yeah, so, okay, I kind of skipped over this, but, you know, returning to ancient whole grains, brown rice, millet. Millet is something that our ancestors ate. You know, up until recently, you know, a lot of this good food for our body was taken away by the Green Revolution, and previously to that under colonialism. In fact, there's a disease called pellagra that comes from eating white rice. It skyrocketed. No one knew what was going on because they switched from brown rice to white rice. There's cardioprotective elements in brown rice that is missing in white rice. So you basically just simply substituting white rice for brown rice can lower your glycemic response by 23%, and you're reducing it reduces fasting insulin response by 57%. I didn't go into this before, but you want to increase your intake of fresh foods, fermented foods, monounsaturated fatty acids, portion control and water before meals. Water is something that we neglect. 3.7 liters per men and 2.7 liters for women if you can do it. Blue zone, there's different diets that have shown to be beneficial, especially for South Asian, Mediterranean type diets, DASH diets. And then you want to reduce your processed food consumption, your meat consumption. In the blue zone diet, people who live over the age of 100, they don't eat meat more than 4 or 5 times a month, by the way. That's how they do it. Trans fats, you don't want to have any trans fat in your diet. You want to eliminate refined carbs. And by the way, one other thing that's interesting, smoothies, a lot of people think smoothies are healthy. You're basically turning fresh fruit, which is actually good for you, into a juice, which is terrible for you. You're removing all of the healthy insoluble fiber that should be accompanying eating a fruit, and basically you're skyrocketing your sugar level inside your bloodstream, and your insulin has to respond to that, and it turns it into fat.
Okay. This is really the last one. As you can see, there's so much interest in this topic, and I'm really grateful that there is this much interest. How about quinoa? Is it a good alternative from?
I would say it's excellent. I mean, it's actually got a lot of protein in it, and yes, I mean, I have no problems with quinoa. It's an excellent grain.
Okay. Dr. Tajuddin Ahmed, any closing remarks you have?
I think maybe you can get Mubin's permission to present his talk somewhere if you are that interested in presenting in the communities. One of his friends already trying to do it. He's a cardiologist in Tennessee.
Absolutely. This is definitely something that needs to be promoted and talked about more in all communities. Dr. Syed, any final remarks before we close tonight?
I think, the key thing is, again, just be extra careful, know that we're made differently. A lot of the studies that, a lot of the findings that you may find in the literature are not specifically done in South Asians. So, and the nice thing is it's really good news. Most of this can be reversed. If we just change our lifestyle, we can actually protect ourselves from this devastating plague.
Well, I think the dietary changes should take place early in life.
Yep.
I would always say that if a child puts his hand on Big Mac, you are done and you're cooked.
That's true. Yeah, and that's where there was a study that came out recently. The earlier you can correct your lipid profile, the better you will be. Even in your 20s or 30s, if you correct your lipid profile, you'll have benefits later on in life. That can't be as good as when you correct it only in middle age. It's much
these
better
are the
to correct
moms
it early.
who needs this knowledge. That's where the children get their food. And women probably do not have that much of information to feed the kids the right way.
Absolutely. And my only closing remark, excellent information. Work with your primary care doctors, work with your cardiologist. If there's a cardiologist in your community or primary care doctor, talk to them about coronary CTs or calcium scores or fasting lipid panels. Talk to them about your family history and risk reduction. We're not the same as the general population, so you definitely need to establish that relationship. We're fortunate in the South Asian community that there's a large physician population, so please reach out, whether to anybody on this call or anyone in your community, to get the proper risk stratification and imaging studies if that need be. Thanks for joining, everyone.
Thanks.
See you soon. Take care.